Hey everybody, welcome back to yet another journal club. Those of you who have been attending our journal clubs, I'm Dr. Oliver Medvedik, coming to you live-ish. I don't know if there's a lag, but as live as we can, along with everybody else joining us. Steve Hill, Fatima, Sven, Victor in the background, and everybody else joining us who will be, I guess, asking questions. And we're having our journal club on October 1st. Today, so we're a little bit late, so we're going to be having two journal clubs this month. We're going to be having our September journal club now, and then a Halloween special journal club coming in later. I think it'll be on October 29th, so stay tuned for that. I am obviously representing LEAF, Life Extension Advocacy Foundation, and do check us out at lifespan.io. So this journal club, we're doing a paper that's basically a follow-up to a paper we did a while back. I don't know if it was the last paper we did or the paper before the last paper. It was a while ago. It was a couple papers ago. And it was from the Kirkland lab, along with a lot of other co-authors from the Mayo Clinic. And this paper here is a Hickson et al. Paper. And it's a senolytic paper. It's a clinical trial. So this is really neat, and I'm going to put up this paper right now. Let me see, share my screen, and there we go. And this paper is, whoops. Does that look clear to you? You can see the title? Good. So this is eBiomedicine published by The Lancet. And it's a senolytics paper, and this is the first paper they mentioned, the first peer-reviewed trial with a very, very small, modest amount of individuals. I believe there's 9 subjects, and they may expand. There's some trials they do in the paper with maybe 11 subjects, but basically 9 subjects. I believe 7 males, 2 female, and this is the first such trial where they actually show senolytic activity in patients after treatment with Dasatinib and Quercetin. So this is, sort of a big deal. This is the first ever. Now, the previous paper that came out of, the Kirkland lab and collaborators, if you recall that one, it was, they used basically, I believe they also used Dasatinib and Quercetin, and they used it on patients that had a condition called idiopathic pulmonary fibrosis. And they basically, the whole gist of that paper was to make certain that that they had a protocol in place to test these compounds, that there was no toxicity, but they did see some modest amelioration of symptoms of idiopathic pulmonary fibrosis, but they weren't testing specifically for the senolytic activity of these senolytics. They were just showing that the compounds were safe, that they had a protocol in place to go with future studies, and that they did see a modest amelioration of symptoms. I believe they had slightly improved cardiovascular function, but it was a very small trial. It was like 11 patients, but still it was a clinical trial. This one, it takes it up a notch, and they mention at the end of this paper that they're having more clinical trials in the pipeline. So expect to see a lot of these coming out. But the title of the paper is Senolytics Decrease Senescent Cells in Humans. Preliminary report from a clinical trial of D plus Q in individuals with diabetic kidney disease. So that's what they do. They actually do biopsies of these patients to show that senescent cell number goes down. And this is the first time. So I guess that would be really the punchline. This is the first time, stop sharing, that this is actually shown, in a peer-reviewed paper, a clinical trial that's been published, right? So everything up to this point has been done in mice. It's done in, mouse trials, senescent cells have gone down, and also human cells in tissue culture, right? But not in an actual patient, seeing this happen. So seeing an ablation of senescent cells using a drug combination, not more artificial genetic intervention, as you would see, has done in mouse trials. So it's very modest. It's a very short paper, but it's huge for, in that respect. It really sets the bar up, to the next level of testing. So they, there's a lot of background information here that the authors go into, why they picked specifically Dasatinib and Quercetin. I mean, there's a lot of good reasons. One is that these drugs have been studied for a long time. There's, people have been taking, Quercetin for a long time. It's natural plant compound. Sorry, I have a phone ringing here, but in the background, but, it's a working lab. This is, it's not this ain't a sound studio. But anyway, so that stopped. But so people have been taking Quercetin with no problems for a long time, and the combination, the amount that they use is, I believe, a gram, per day. So they dose the patients. So I'm just going to scroll down here to the, to the table 1, which is the patient profile, right? So they dose these patients for 3 days. So it's, it's an intermittent dosage of, I believe, 100 milligrams of Dasatinib, which is a drug that's given to patients. I think it's it's given for isn't it given for a leukemia? Somebody can correct me if I'm wrong, but the safety profile is such that people that have been on Dasatinib have been taking it for months, if not years, for like up to 10 years, like 100 milligrams a day for a long time. So if there's any problems, it usually pops up chronically. And here they're giving only 100 milligrams of Dasatinib for 3 days, so very, very short duration. And Quercetin, much higher dose, I believe it's 2 500 milligram dosages per day, so a gram per day. Again, so very short duration, only 3 days. So they dose patients, so they do tests on the patients here in this paper before administration, and then they dose them for 3 days, and then they check, they check the senescent cell profile, I believe 2 weeks later, to see basically post-administration what has happened. So these patients have a diabetic kidney dysfunction, but otherwise they don't have other problems. They mention, if you want to dive into the paper, they mention, yeah, so Keith said 500 milligrams, typically what supplement tablets contain, incidentally. 500 milligrams, I'm assuming that's Quercetin and not Dasatinib. So yeah, so people have been taking this for a long time. So they don't mention that there's any problems, by the way, with this dosage that people have been taking in this trial. So okay, so the average age was about 69, and here's the profile of everybody here. So they do biopsies of adipose tissue. I believe they take it down from the abdomen, so you don't have any problems with, yeah, Keith says, yes, 500 milligrams Quercetin is normal due to its poor bioavailability. Yeah, so anyway, I don't think they test bioavailability here in this paper. If I'm not sure exactly where they got the drugs from, because if you look in the materials and methods, they say, this is what they administered, single 3-day oral regimen, but what configuration this was, whether it was a tablet, whether it was a powder, what in an emulsion, I don't know. So I don't know exactly. So those of you who are interested in that, please contact the authors, because it doesn't seem to say that there. Anyway, so I'm going to scroll to the first figure here, and really just get down to the data. Because this is the first-in-kind trial. So figure 1, D plus Q decreases human adipose tissue senescent cells. So, this is some microscopic analysis. So you see these look like bubbles. These are fat globules, and you got these little, the rest of the cytoplasm, the cell body here, and this is cells engorged in, these are adipocytes, adipocytes. This is day 0 baseline, and they stain for using antibodies for P16, which is, a marker associated with cellular senescence, and P21, a tumor suppressor. By the way, P16 is used as a marker for cell senescence, but it's not expressed in every type of cell. So I know there's been trials where, people have been trying to selectively ablate stuff with P16, but not every senescent cell expresses P16. I just read a paper dealing with human mammary epithelial cells, which I was going to do for the journal club, but I ended up doing it for my class. And those cells that are senescent, they do not upregulate P16 at all. There's nothing to do with P16, but they do upregulate P21. So, you know, it depends on the cell type. So they look at adipocytes here, and they count basically the percentage of cells that are staining, you know, baseline day 0 and day 14 post-treatment. And this data here that you see on the, you know, on the right is basically the microscopic data. And they blinded these, by the way, for the people that were counting them. So they didn't let, so they mentioned in the materials and methods that, you know, the people that were counting how many cells were stained in the field of view, they didn't know if it was pre-treatment or post-treatment, right? So obviously that's important, you know, to make sure that you don't have any bias creeping in. And you do see a statistically significant decrease for both P21 cells, a bit less for P21 staining, and P16 cells in adipose tissue. And also for senescence-associated beta-galactosidase, which is another marker that's associated with senescent cells. So here's a little arrow showing what somebody who would be looking at a field of view would see with an SA beta-gal stained cell. And this is the type of plot you get. All these little colored dots represent different patients. So you have 1, 2, 3, 4, 5, 6, 7, 8, 9 patients. And I believe each color represents a specific individual patient. And I was just curious. I was like staring at these colored dots here. I'm gonna go to chat here. They do mention from Sven, I don't know what that is, in my packageinserts.bms.com. What is that?
Well, if I can clarify, the authors does say this link in their paper. So it seems that the Dasatinib came as tablets.
Oh, at tablets. Okay. So
but they don't mention anything on the Quercetin where that came from.
Okay. Okay, good to know. So the Dasatinib probably is in a pill form because it's a prescription drug, so it's probably something standard. Okay. So yeah, so I was just interested looking at these figures here because, you know, every patient is different, right? Because you see a lot of noise here, but if I look at, I'm assuming that, you know, the dark blue here and the dark blue in day 0 and day 14 are the same patient, right? So they're basically are given a color coordination. But it's interesting because there's some patients who are, you know, don't respond. There's a few, like this one in pink, right, actually goes up after day 14. I don't know what's up with that. So you have patients which kind of buck the trend, and I'm not sure if that's because maybe they have more senescent cells to begin with. I don't know. It's interesting so like the pink one goes up here. Everything else, well, the red one, yeah, kind of goes down a little. So I'm just seeing, looking at these little dots to see where the outliers could be, right? So there might be, so for people doing future studies, it might be interesting to see what the response rate is for different patients and why some people don't respond to as much to this type of senolytic treatment. Maybe they need higher dosages. Maybe maybe they have more senescent cells to begin with. I don't know, right? So it's kind of interesting to it's good that they had these little dots here so you can actually see how individual patients are performing. Like here, this dark blue kind of doesn't change, right? Or goes up slightly, whereas everything else or actually in this orange one too, but other ones go down, right? So what's up with some patients? I don't know. So I'm just pointing that out, that when I was kind of looking at these dots. Anyway, but the trend is there, even with a very small population of patients, which is 9 patients, right? I mean, that's as low as they can get to get any kind of statistically meaningful, kind of trend. But it's very promising that the trend is there, that you have an ablation of after a very short period of time, right? 3 days treatment with these 2 compounds, 2 weeks post-treatment, punch biopsies, adipocytes, and you get a decrease that's statistically relevant. So that's very promising. Go back to the paper. So this is an adipocytes. So next they look at something that correlates with senescence, which is the attraction of macrophages and what they refer to as crown-like structures, because cells that are senescent tend to secrete pro-inflammatory factors. They tend to attract macrophages, and that's something that they also wanted to see. If it correlates with a removal of senescent cells, you should also see a decrease in this immune response, and that's what they see. So CD68 is a marker for macrophages, and it's the same type of microscopic analysis, immunostaining, and you have a very similar type of kind of effect. You have a decrease. They say p value is 0.001, and it's be interesting to see why some people, there's who are the outliers here? That again, it's probably a follow-up studies, if anybody's thinking about doing them, maybe drill down a little deeper and take a look and see what the baseline of senescent cell numbers are for certain individuals, right? Because, you have 9 individuals, and everybody's wildly different in their, if we look at, the average age is 68.7, but that's just the average age. So there could be a lot of differences there as far as senescent cell burden. Okay. Crown-like structures are basically like an accumulation of immune cells, such as macrophages. So they're just referred to as crown-like structures because I guess they surround the cells. And you do see a decrease, in these crown-like structures, quite considerable in adipose tissue, which basically correlates with a less of an immune response happening post day 14, post-treatment, right? The third thing they do is a little different, is they look at pre-adipocyte proliferation, because senescent cells obviously don't divide, or they divide very slowly, or they start stopping division, right? That's one of their hallmarks, is they don't divide, and their morphology changes considerably. They release factors they're not supposed to release, and so on and so forth. So what they did here is day 0 and day 14, they took biopsies of patients' adipocytes. They cleared the macrophages. They passaged the cells 3 times in cell culture. See, I'm going to the chat here. Yes. Okay, we'll hold that off for a little while. People are asking about future trials. I'm not sure. But anyway, going back to so this is a proliferation assay, and essentially what this is my understanding is they passage the cells 3 times, and then they stain it with tetrazolium to basically test for cell concentration. So metabolically active cells, the number of cells should go up if they are actively, dividing. And day 0 you have less, and day 14 post-treatment, the cluster of cells that are passage goes up, and they say it's significant, p-value of 0.027. Obviously we need greater numbers, and there's a lot of variation here, like these orange, the orange and the pink here are complete outliers, right? So why that's the case for these guys, for these 2 individuals, I don't know. Maybe it has something to do with senescent cell burden to begin with for these folks. So that's for adipocytes. What they wanted to look at next is basically do same assays, similar assays, but look at epidermal senescent cells. So basically look at cells within the skin, right? So basically different, they were looking at epithelial cells, they're not looking at adipocytes, so different cell type. And this is staining. So again, day 0, day 14, biopsies. So they're staining for P16, P21. And this CD1A, which is for Langerhans cells, these are cells that are, I believe these are antigen-presenting cells. And I'll get to that in a moment. But you see the same trend here, with your concomitant variation in individuals, same trend happening for both P16 cells and P21 cells, after these have been counted in a kind of a blinded count under the microscope. the Langerhans cells, it's the immune response is different. They don't see, so I believe, I'm not sure what they were expecting to see here. If anybody can chime in here, like if the cells were senescent, would you have increased Langerhans cells that are then increased, are about that later in the paper either. Lastly, what they do is they do an ELISA assay. This is an ELISA type assay using the system using beads. And I'm not certain exactly what the percentile, obviously blue means more and yellow means less, but percentile what, I'm not really sure. I was looking in the materials and methods. These are basically senescence associated, factors, secretory factors in blood plasma, and then they basically measure the levels. But I'm not sure what this percentile is in reference to, what the reference, what it's normalized to. Just that it's high in this 85%, range. Maybe that's 85% of what would be normal and what would not be normal. I'm not sure. So I tried looking at materials and methods. I couldn't find that. Just by looking at it, you could see just by eye from this ELISA assay that the number, or the percentile decrease is looks significant, right? So you certainly have a lot more. So these are the individuals that were color coded previously: 1, 2, 3, 4, 5, 6, 7, 8, 9. It'd be interesting to see. So this is day 0. You can already see some people already have a lot more circulating, senescence-associated secretory phenotype factors. So, things that are things that promote inflammation, inflammatory markers, chemokines like IL-6, for example, right? Matrix metalloproteases, that kind of thing. So, some people are, so this one that's in pink, which was kind of an outlier before, you could see that this looks different. So they had a lower SASP to begin with than day 14, which looks kind of unchanged. So that's kind of interesting. Maybe, maybe I said earlier that maybe they had a higher incidence of senescent cells to begin with, but maybe they had a low incidence to begin with. So Dasatinib and Quercetin didn't have as much of an effect on this individual. So it's interesting to see that, looking at this profile of these individuals. But in general, you could see the trend is that you have, an overall decrease of these senescence-associated circulating, factors in blood plasma using this ELISA-based test, which is basically it's an enzyme-linked immunosorbent assay. So you use antibodies that bind to factors, and to a very high specificity and high resolution, you can detect them in blood. So the trend is there. I'm going to stop sharing. So this is the first in-kind such study. I kind of zipped through this paper because it's, there's not that many figures. It's only nine participants. There is a lot of variation, as we saw from kind of the panel at the end with the senescence-associated secretory phenotype between individuals. But the trend of looking just at all those individuals is there, in that senescent cell number goes down, in 2 different tissue types. And the circulating senescence-associated secretory phenotype factors go down in the blood plasma. And this might suggest also, they mentioned in the paper, that, there's a lot of room for improvement here, right? They just started with this one combination, because they mentioned in the paper that also Dasatinib and Quercetin were picked because they target, I think they did an analysis. They did I think they did a bioinformatics type analysis where they looked at pathways that that these compounds target for senescent cells, and they target distinct pathways that can induce apoptosis. So they're not just targeting one pathway, so they can target multiple nodes that they mention to induce apoptosis in cells. So that's another reason why they picked this double drug combination, is that Q and C, target 2 different nodes of two different anti-apoptotic pathways that are upregulated in senescent cells, and also that that the safety profile of these drugs is well known as well. So it was a good combination to pick. But like the authors mentioned, there's room for improvement. This is a first of its kind study, and this is I'm hoping heralding a new era. They mention that this certainly bodes well for, and I never heard of it mentioned this way, but the Geroscience hypothesis, right? Which is basically that if you target things that affect senescent cells, you can hit multiple chronic diseases at once, right? Which is basically what everybody in the aging field has been saying for a long time. I just didn't know that it was referred to as the Geroscience hypothesis. But that's what they mentioned in the paper. So this certainly gives credence to that, right? So there appeared to be an improvement in the last paper that came out of the Mayo Clinic on slight improvement, but again, a very small trial for idiopathic pulmonary fibrosis. And now we're actually seeing in human patients for the first time an actual clearance of senescent cells using this very, very short-term treatment. So this is not even an aggressive senolytic treatment. This is like a very short-term treatment, and you're getting a measurable, statistically significant response from biopsies, which, considering all the messiness of individual physiologies is pretty impressive, I think, for 9 individuals. And, the authors do at the end of the paper just throw out a caveat there. They're optimistic, but they also say they're very cautious, be cautious because they mentioned the first clinical trial of senolytic agents was only reported in January 2019, right? So these are all preliminary. Fewer than 150 subjects have been treated with these drugs in this context of clinical trials. So what the long-term effects are, we are cautiously optimistic, but this is still pretty new. So if you're interested in later trials, they mention in the discussion of this paper, and I'm just reading out of this paper here. So there's later phase trials. There's a randomized controlled trial that Kirkland and collaborators are currently conducting using DNQ, I think, for idiopathic pulmonary fibrosis. There's one for frailty in elderly women using Fisidin, and there's some other ones. So there's more and more of these trials that are being pushed through the pipeline now. So I think a lot of credit is given to the authors on this paper for kind of blazing the trail here for this class of drugs. So far for this small trial, everything was positive. Nobody had any severe reactions, not that was expected. And the drugs performed as a senolytic should perform, or hypothesized, predicted to perform. So, very good. I mean, let's have more of these trials. And now I'm going to go to the chat because we have here, I would like to ask if trials of Dasatinib and Fisidin have been considered, from Steve to everyone. I don't know. I know they've been done individually, Dasatinib and Quercetin, Fisidin alone. I think Fisidin and Quercetin, but I don't know Dasatinib and Fisidin. I don't know if that combination has been tried. Is DNA methylation measured after DMB hit and run study? Not in this trial, no. DNA methylation was not. If not, would we expect it to reduce after sending senescent cells in? Well, I mean, just the bulk methylation, just the change in the population, the methylation status should change, right? If you're clearing out senescent cells, then yeah, I would predict that. And Victor said, anecdotally, my grandmother and her husband has had improvement in joint pain and flexibility from 1 week Fisidin treatment. So 1,200 milligrams a day. It would be interesting to go DQ next. That is interesting. So basically 1 week, 1,200 milligrams a day Fisidin, huh? what brand? I'm just curious. Not that you don't have no
Well,
financial
I mean,
ties.
I used this brand Doctor's Best. So that
I tried that one too. I used it just short duration. I don't know if I had an effect on me. I had tried quercetin and Physidin. I took how much did I take? I wrote it down somewhere. I did take I don't know. Yeah, I took about I did take like 8 grams over the duration of like but I mixed it with a bunch of other things, coconut oil, medium chain triglycerides, and some other stuff to try to improve its solubility. I don't know if I noticed an effect. If anything, there was no negative effect. So I mean, that was like 6 months ago. So maybe I need to up the dose or
so of course it's more interesting with the really old people who are like 80. They should, see more pronounced.
Right. Okay, so any questions coming in from anybody else? So Apigenin, so Steve, to everyone, Apigenin and Quercetin also reduces inflammation and increased NAD plus according to a 2012 Sinclair study. Yeah, it makes more sense now in this context. So, so yeah, it's interesting that people are looking at combinations of senolytics. Certainly, the justification given in this paper is that you're targeting pathways that are active, that you have multiple pathways that are upregulated to prevent apoptosis in senescent cells. So you want to target, several nodes that are predicted to be active in combination.
Well, that ties in with the Campisi work, doesn't it? That she's conducting at the moment, looking at the subpopulations of senescent cells, or heterogeneity, or whatever I think it's heterogeneity. They're looking at the types and subtypes of senescent cells, and it really sort of explains why no single senolytic is going to do it all. As Peter de Keyser was saying, we interviewed him last year, and he mentioned the idea of cocktails. Certainly something that we're looking at MMTP as well.
Mm-hmm.
We're testing cocktails on mice, senolytic cocktails, obviously not pina coladas and Bahama Mamas, although that would be good. I wouldn't say no to a Bahama Mama right now.
Huh.
But that's another story. But yeah, it does make sense that different kinds of senolytics are going to address these different subtypes of senescent cells potentially. It kind of makes sense. But yeah, it's interesting for me that I mentioned Apigenin and Quercetin, which reduced inflammation, or CD32, which is present in the SASP. And it kind of feeds into the whole idea of, well, the next question is, do senolytics influence NAD? I'd like to see someone actually test the senolytic to see if there is any change in the amount of NAD available. I suspect that it may increase NAD production.
Mm-hmm.
Certainly that Apigenin and Quercetin paper suggested it does, and now knowing that at least one of those compounds is senomorphic or senolytic, depending on your point of view, I think it might be worth looking at that in that context. And also Apigenin. Maybe Apigenin is also senolytic. I think they're chemically virtually the same.
Yeah, I don't have the structure. I could look it up, but I remember we were doing a structural comparison a few journal article clubs back, and they were structurally close cousins, if not brothers.
I think they are, yeah. So I'd be interested to see if they had any senolytic properties as well. And again, that Apigenin could also be another candidate alongside Quercetin and Dasatinib, for a deeper look. And obviously it comes from chamomile, which is a tea which has long been used to reduce inflammation. So makes sense.
So yeah, this is the first, surprisingly or not surprisingly or pleasingly, this is the first paper that's actually shown evidence of clearance of senescent cells in a living, breathing, walking set of human beings in a clinical trial, right? So, so that certainly raised the bar considerably, so major props to, all the researchers at the Mayo Clinic, who've, it was not that long ago that we did the paper on idiopathic pulmonary fibrosis. And now, clearly they have a lot of these trials stacked up, and we're going to be seeing more of them, come out one after the other. So it's a lot of work. There's a ton of authors on these papers, right? So even with a small trial like that, there's just a lot of work involved in characterizing this. So showing that it's effective, and and everybody in the aging field is excited because you're hitting potentially a lot of chronic diseases at once, right? So so it bodes well that that the safety profile for Senolytics is validated and is being validated, and like the authors, I'm also cautiously optimistic. You don't know what the long-term effects are for massive senescent cell clearance, but so far so good is what I'm going to say. As far as the action of these drugs. So
yeah, we'll take that as a starter for 10.
Yeah, so far we haven't seen any negative effects.
I wonder a bit also about, you have quite a few people who have been taking Dasatinib for leukemia. What about
Yeah, there's a lot of epidemiological data that could be kind of culled from this, right? So and unfortunately they're not taking combinations of Dasatinib and something else, but like they said in this paper, people have been taking Dasatinib for like a decade, right? So a long time. So is their senescent cell profile different from what the average person would be? Despite the, obviously it gets complicated, right? Because if they're taking this drug and they have leukemia and they probably had radiotherapy, and that's going to mess with their whole senescent cell population. So it might be really hard to because fortunately or unfortunately, I don't think we have a healthy population of people taking Dasatinib for 10 years. So it's going to be a little tricky. But if there is a way to look through that data, then there could be something interesting there.
And coming to cancer, actually, there was another paper published. It was in mice this month, previous month. And that was a paper where they actually showed that when you treat mice with doxorubicin, which is a chemotherapeutic agent, it induces cellular senescence, and that this cellular senescence actually can cause an increase in blood clotting. And one of the things that is very well known in people who have cancer is that they sometimes die from clots, causing strokes and heart attacks. So potentially Senolytics could actually be used in the treatment in cancer to prevent this side effect. And of course, it has multiple potential other benefits in cancer therapy as well. But this is probably one of the new ones. I hadn't heard before that blood clotting was regulated by senescent cells. They used the genetic model of removing senescent cells, so not the Senolytics, but that's all very interesting for future research. And of course, then the question also is, would Senolytics potentially decrease the risk of blood clotting in healthy people caused by senescent cells? And so could Senolytics prevent strokes and heart attack?
Right.
That paper, it was very interesting, actually. We covered it. Very interesting indeed, and there's a before unknown mechanic of senescent cells. This ties into the comment as well about cancer that Tony Fatika's just asked on Facebook. He says, I wonder how Senolytics will affect elderly people over 80 in regards to cancer. Clearing out chronic senescent cells may increase cancer in that range, ?
Well, yeah, I mean, the data actually would actually suggest it's the opposite, that you would decrease cancer because you're reducing inflammation. So you're actually you're not preventing cells from getting into senescence or cancer cells from potentially getting into senescence, but you're actually just clearing out senescent cells, right? So these cells that are problematic to begin with are just cleared out, and the cells that are left are the cells that are metabolically okay, that are still not senescent, that are dividing in a healthy manner, right? Not things that have gone. So if a cell goes into senescence, it's usually because something has gone wrong. And there could be a mechanism for the cell to stop dividing because its telomeres have gotten too short, or there could be some other type of DNA damage. So you're actually pushing those cells to get killed off, get removed, get apoptosed. So if anything, I would predict, that you would, your cancer rates would go down. I'm trying to find a reference to where there's I'm trying to find a specific reference to another paper I just read where there's some evidence suggesting that the cancer levels, at least in some model, go down. But anyway, I'll find that. But that's what I would predict. Now, there might be another problem with getting rid of senescent cells in somebody really, really elderly, because it's like, I've been thinking about this. I'm like, what if like 90% of your cells are already senescent, right? I mean, if you're functioning at such a stage that where like most of your cells are senescent, then you probably don't want to. I mean, I'm just hypothesizing here. I don't know what the percentage of senescent cells is off the top of my head for somebody who's a super centenarian, right? But clearly, if all you have are senescent cells, you probably don't want to ablate all your senescent cells. If that's what's holding you together. That's kind of a morbid joke, but not really. I don't know what the percentage of senescent cells there are for somebody who's because obviously your replicative potential for all your other cells, your normal cells, goes down as well. So if you get into some extreme state of age, and I don't know what that extreme is, and somebody says, isn't it like 20% at most? And somebody says tissue depending. Yeah. So I don't know off the top of my head what the percentage is in different tissues, but or what the cutoff is. So if you ablate 20% of your total cell mass in a particular organ that's senescent, would that cause homeostasis to somehow go awry? I don't know. I think it might have to be pretty extreme. But again, I don't have the data on that. I don't know. At least for the numbers that we're talking about here, it seems that ablating is a good thing, and that it's going to.
Wouldn't that lead to like tumorlysis syndrome, something similar to that?
Yeah, I mean that's a possibility, but I don't know if apoptosis would actually lead to that, right? Because tumorlysis syndrome is more a consequence of. So when they did trials with, so when they say Senolytics, I don't know. It's kind of a misnomer because the cells aren't really lysing; they're apoptosing, right? And they're being taken up by macrophages. So it's probably senopoptotic, right? I don't know. I'm just basically throwing a word out there, right? It's not senolytic, right? Because that just to me implies necrosis. Like if you have a cytotoxic T cell that basically causes a cell to rupture or release contents, then you get. I believe that you get a syndrome, right? Where essentially you have I forgot what you called it, tumorlysis syndrome. Yeah, and I remember reading a paper about this a while ago, and you basically can induce inflammation and all kinds of problems because you release all of this stuff into your bloodstream. But I don't think that's what's happening here. You have a controlled apoptotic event. You're not having your cells basically rupture and spew their contents everywhere. So I don't know. Maybe somebody can correct me if I'm wrong. If lysis is maybe a bit of a misnomer here, and it's more senopoptotic is what we're actually talking about here.
I think you are right, Oliver. I mean, it does seem that Senolytics work by inducing apoptosis and not by necrosis, which will probably be bad. Tumorlysis syndrome will be one example, but you also have, like, if you have crush injuries or other types of injuries, you have lots of cells that just burst, and then you get all types of really acute problems very quickly. So, that will definitely not be a good idea to induce necrosis.
Right. So, yeah. Anyway, I think I might actually have to leave early in the next few minutes, because I have a student waiting out the door right now who needs to run an experiment back there. I don't know, it seems like we've covered the basis on this paper up to this point. If there's any other stuff that we can wrap up in the next 5 minutes, perhaps.
I think we've covered all the bases there. It's a great first step that shows, that the Senolytics work kind of like they do in mice, but in humans, which is great. Obviously, we have to temper that with the fact that it's a small study, but I think it's promising. So I think we've covered that. The only other big news, really, Oliver, is we have launched the campaign on lifespan today as well, haven't we?
Yes. Is that official? The Mito mouse, did that launch officially today?
It did, yeah. That has launched a few hours ago. Mito mouse.
And Keith has been working furiously behind the scenes, along with everybody else, to get liftoff to happen. So yeah. Please check out our latest campaign on lifespan.io, so we can keep doing the good work here.
Yeah, that's a mitochondrial repair project, which has been in the works for, quite a long time with the SENS Research Foundation. And this stage of the project, this is the second one that they've run on Lifespan with us, is actually to bring the proof of concept to mice. So this will be the first example of migrating mitochondrial DNA to the cell nucleus to see if they can reverse aberrant mitochondrial behavior. So that'll be great if it works in mice, because then it'll be the next step to humans. So do check that out at lifespan.io. And that's about it, I think, from us. We've covered some exciting stuff today, and obviously I'd like to thank the Lifespan Heroes, our monthly patrons, who make these shows and many other things that we do possible. And if you'd like to learn a little bit more about that, you can visit lifespan.io/heroes if you'd like to get more involved. And I think we'll be back around Halloween for a spooktacular edition.
Yes, indeed.
Of Journal Club. So I'm sure Oliver will titillate us with something exciting. It was the glowing, the Alzheimer's lights, wasn't it, last time?
Oh, yeah.
Which is interesting, the light therapy. So perhaps we should maybe something a little bit more unusual.
Well, we'll have some Halloween props.
And we will, of course, have some Halloween props. Yep, we always do.
We should do a paper on parabiosis.
Frankenstein's mouse.
Well, perhaps there'll be a parabiotic human study coming up in time for Halloween.
There is actually a new Convoy paper that's just come out, by the way, Oliver. That is based on the original parabiosis work, where they show the rescue of tissue regeneration in multiple organs.
Okay, well, let's put that on our list. Also, there's a paper that just came out in Drosophila where they test a triple drug combination, I believe, and show, I think, the longest extension thus far with a drug combination. I think they use lithium, rapamycin, and something else.
Wow.
And each of them is shown, and each of them has been shown to have, so basically in combination, they show an additive effect, which is very interesting. More in line to, yeah, we're more in line what we're talking about. If you basically, look at, do bioinformatics and look at pathways that, have not so much overlap, targeting multiple pathways at once might have a additive or synergistic effect. But anyway, there's lots of papers that we have not decided yet, but we will keep you posted and let you know what we actually choose for Halloween.
I'm going to be on the edge of my seat until we find out. We'll see you next time.
All right, folks.
Everybody for joining us at home. Take care and I guess stay healthy. That's the name of the game, right? See you later.
Bye.
Right.